Dr. Baliga here. This podcast is on the utility of Alpha-1 Adrenergic Receptor blockers to prevent acute respiratory distress syndrome and mortality from cytokine storm syndrome. The lead author of this paper is Dr. Joshua T. Vogelstein, PhD, who is an assistant professor in the Department of Biomedical Engineering, Institute of Computational Medicine, the Johns Hopkins University, Baltimore, Maryland. The coronavirus disease, that is COVID-19, caused by the SARS-CoV-2 virus, includes hyperinflammation in the lungs and other organs, and almost always compromising function and causing high morbidity and mortality. Disease-modifying strategies for these conditions include antiviral agents and preventing hyperinflammation with immunomodulators or immunosuppressors. Dr. Joshua Vogelstein and co-authors in a paper submitted to JCI, Journal of Clinical Investigation, propose an approach using the latter strategy of hyperinflammation prevention. Specialized cells of the immune inflammatory response communicate with each other by secreting peptides called cytokines. And in some patients, there's a huge release of cytokines, and they experience the cytokine storm syndrome, which is characterized by elevated pro-inflammatory cytokines including interleukin 6, IL-2R, tumor necrosis factor alpha, and granulocyte colony stimulating factor, among others. One approach that has been proposed to ameliorate the cytokine storm syndrome is blocking IL-6 signaling. IL-6 levels predict COVID-19 severity and in-hospital mortality, and I've discussed this in an earlier podcast, which was shown in an article from China and published in The Lancet. Therapies utilized are monoclonal antibodies against IL-6, such as ciltuximab, and IL-6 receptor blockers, including tocilizumab and sarilumab. Clinical trials are currently being conducted in COVID-19-induced cytokine storm syndrome. However, these antibodies are extremely expensive and have side effects, including the risk of suppressing antiviral host responses, which include prolonged immunosuppression and potential adverse reactions. Dr. Vogelstein and co-authors argue that there is another potential target for preventing hyperinflammation, and that is the catecholamine system. Catecholamine release precedes hyperinflammation and enhances inflammatory injury by augmenting cytokine production via a self-amplifying process that requires alpha-1 adrenergic receptor signaling. In mice, catecholamine synthesis inhibition reduced cytokine responses and increased survival after inflammatory stimuli. The alpha-1 receptor antagonist prazosin, but not beta-adrenergic blockers, offered similar protection, showing that this drug class can prevent cytokine storm syndrome. They argued these preclinical findings provide a rationale for clinical studies to assess whether alpha-1 adrenergic receptor blockers or antagonists can prevent cytokine storm syndrome and its sequelae. Since there were no controlled trials studied whether these alpha-1 adrenergic receptor blockers reduce cytokine storm syndrome, ARDS, or mortality, Vogelstein and co-authors conducted a retrospective analysis of two cohorts of hospitalized patients. They were evaluating patients taking alpha-1 adrenergic receptor blockers such as doxazine, alfuzosin, prazosin, sildosin, terazosin, or tamsulosin for other chronic disorders unrelated to ARDS, such as benign prostatic hyperplasia, hypotension, and post-traumatic stress disorder. Given that these medications are typically used in benign prostatic hyperplasia, most of the study cohort were men, aged between 45 to 64. The first cohort comprised of 13,125 patients diagnosed with acute respiratory distress, which is often a precursor to ARDS. In this cohort, taking Alpha-1 adrenergic blockers compared to non-users was associated with a 22% lower incidence, relative risk reduction of mechanical ventilation. P-value was less than or equal to 0.009, and a 38% lower incidence of ventilation and mortality, p-value less than or equal to 0.023. They next specifically assessed the most commonly used Alpha-1 adrenergic blocker, tamsulosin, which is selective for Alpha-1A and Alpha-1D receptor subtypes. Tamsulosin is used almost exclusively for BPH, thus reducing the likelihood of confounding by indication. ARDS patients taking tamsulosin had a 35% lower incidence of mechanical ventilation and a 55% lower incidence of ventilation and death, p-value less than or equal to 0.002 and p-value less than or equal to 0.015 respectively. In contrast, beta-adrenergic blocker utility did not affect either clinical outcome. The second cohort comprised of 108,956 patients diagnosed with pneumonia. They found that Alpha-1 adrenergic receptor blockers compared to non-users was associated with a 13% lower incidence of mechanical ventilation, p-value less than or equal to 0.001, and a 16% lower incidence of ventilation and mortality, p-value less than or equal to 0.04. Pneumonia patients specifically taking tamsulosin had a 16% lower incidence of mechanical ventilation compared to non-users, that is no Alpha-1 adrenergic receptor blockers, and a 20% lower incidence of ventilation and mortality, p-value less than 0.001 and less than 0.042 respectively. Again, beta-adrenergic receptor blockers did not affect either clinical outcome. In their discussion, they emphasized, given the poorly understood relationship between COVID-19 and hypertension, it is important to note that non-receptor subtype selective Alpha-1 adrenergic receptor blockers such as prazosin are used to reduce blood pressure, whereas receptor subtype selective drugs such as tamsulosin have fewer hemodynamic effects. They argued Alpha-1 adrenergic receptor antagonists are inexpensive and administered orally, enabling widespread use if prospective trials support their efficacy and safety. Beyond COVID-19 and other pneumonias, they said that Alpha-1 adrenergic receptor blockers may reduce cytokine syndromes and their sequelae in adaptive cell therapy and autoimmune rheumatic disease. This paper is currently undergoing peer review and prospective trials are contemplated.